Good morning, my name is Alex Sanchez. I'm going to be the PA student taking care of you today. Can you just confirm your name and date of birth?
Yes, Michael Anderson, 12/21/1990.
Perfect. The patient appears awake, alert, and oriented with no apparent distress. He's well developed, well nourished, appears his stated age, his normal gait and motor activity, good hygiene, no bad breath or body odors. Before we perform our physical exam, we're always going to start with washing our hands as well. So we're going to begin with the abdominal exam. We're going to start off, as always, with our inspection. We're going to check out his skin. It looks like we're just checking for any striae, any flame patterns, the hair distribution, any rashes or lesions, anything that would be out of the ordinary in our patient. It looks like negative for all of those things I just mentioned. We're also going to check his umbilicus. We're checking for the contour, making sure that it's center medially. Peristalsis is not going to be able to be seen in this patient. We're going to check with tangential lighting the pulsation of his aorta, which we're able to see right around here. Perfect. And we're also going to check if there's any venous abnormalities. I don't see any telangiectasias. Doesn't look like there's any abnormalities that we should be concerned about at this current time. So now we're going to begin our auscultation part of our physical exam, and we're going to be checking out his renal arteries, femoral arteries, the aorta, making sure that there's any abnormalities, any bruits. We're also going to be checking out every quadrant to make sure that his bowel sounds are within normal limits as well. To check the arteries, we're going to switch over to the open bowel side of the oops, right here. I'm just going to go under your waistband just a little bit, right? Everything was negative. There was no bruise. So now we're going to begin the percussion stage of the physical exam. We're going to be checking out all four quadrants to make sure that there's no abnormal sounds, which would be sounds of dullness. We have a gastric bubble up here. We have our liver over here. And we're just making sure that it's tympanic, basically. So we're going to start off right over here. Looks like everything was within normal limits. Everything sounded tympanic. All right, so we just asked our patient to put his knees up so that we can relax the abdomen. We're just going to percuss really quickly his liver, and we're going to find the upper border by going down from the top and the lower border from going up from the bottom. All right, so from the top, we're going to start right around here. Still tympanic.
Like it makes a difference a few dollars because then like
more dull. This is more. That's tympanic actually.
That much because like the options you can use, so like only $1 or $2. You can't like the max was like $3.
Yeah.
Okay. So upper border starts right around here, and then from the bottom we'll go right down here. Gastric bubble. And we're starting to get more dull right around here, which makes sense because the shape of the liver is right around here. Next, we're going to palpate the spleen. We're just going to go ahead and find the left lower intercostal space, which would be right here. And we're just going to percuss. That's the sound of tympany, and that's a good sign because if it was dull, we would expect it to be dull with splenomegaly. I'm sorry. Now we're going to ask our patient to take a deep breath in. Percuss one more time. You can hold your breath. Okay, so everything was negative. No splenomegaly is suspected in our patient. Next, we're going to be percussing the kidney just to check if there's any costovertebral tenderness. And we're gonna switch to the other side. Michael, can you just flip over things? Michael, was there any tenderness while percussing? No? Perfect. Now we begin the palpation step of our physical exam, where we're going to palpate lightly on all four quadrants, then deeply, just to check for any tenderness, and just keeping in mind which organ systems are underneath which quadrant. All right? Any tenderness? Any tenderness? Tenderness? No? Anything? Perfect. Now we're going to do deep palpation, 2 hands. Any tenderness?
No.
Nothing?
No.
Okay. Anything? Perfect. And we're also going to be doing the palpating the suprapubic for area, just to check for any bladder distension or abnormalities. Any tenderness? And we're also going to be palpating the aorta, just to make sure that there's no abnormalities there either. All right.
The liver edge. Right? No, it's called liver edge.
All right. Looks like there was no abnormalities that were observed during this physical exam.
We don't have to.
Now we begin the palpation step of our physical exam, where we're going to palpate lightly on all four quadrants, then deeply, just to check for any tenderness, and just keeping in mind which organ systems are underneath which quadrant. All right. Any tenderness? Any tenderness? Tenderness? No? Anything? Perfect. Now we're going to do deep palpation, 2 hands. Any tenderness?
No.
Nothing?
No.
Okay. Anything? Perfect. And we're also going to be doing the palpating the suprapubic for area, just to check for any bladder distension or abnormalities. Any tenderness? And we're also going to be palpating the aorta, just to make sure that there's no abnormalities there either. All right.
The liver edge. Right? No, it's called liver edge.
All right. Looks like there was no abnormalities that were observed during this physical exam.
We don't have to.
We also have to deeply palpate for the kidney, so we're going to go right around the area. Any tenderness at all?
No.
All right. So I'm just going to ask you to sit up just a little bit. No, you just sit up a little bit. Perfect. So right now we're going to, you can lay back, it's fine. I just wanted my hands behind you. You can lay back. We're just going to try to find the inferior border of the liver, and we're just going to do that by holding the back by the 11th and 12th ribs, and in the front we're going to go move superiorly, looking for the inferior border of the liver. Can you take a deep breath in? Alright, the border starts right here.
Literally there, it says it, but I
Alright, perfect.
feel like I'm gonna do it
You can
wrong.
take a deep breath out. You can breathe normally. Doesn't look like there was any tenderness, and it looks like it was within the 6 to 12 centimeters on the greater side of the liver, and between 4 centimeters on the other side as well. There was no indication for hepatomegaly. We're going to be performing the Murphy sign now. We're just going to check for any gallbladder abnormalities, any tenderness. We're going to use a hook technique by hooking onto his ribs like that. And we're going to ask him to take a deep breath, and we will be trying to feel the gallbladder for any tenderness. Alrighty, any tenderness, pain, anything like that? Alright, perfect. That was a negative Murphy sign. So we're also going to perform some special tests to check for any ascites, any appendicitis, things like that. So I'm just gonna ask, Michael, I'm just gonna ask you to put your hand just like that right here in the middle. Put some firm pressure on there. I'm gonna just check on this side. We're gonna feel if the vibration I do with this hand on this side, if we can feel it. And this will be a check for ascites. Alrighty, that was negative. We're also gonna be checking for McBarney's point. And can you just bring down your knees for me real quick? thank you. Just gonna find his hip bone, which is right here. This is the iliacus. Here's his umbilicus. The measurement here, we're gonna go 1/3 of the way up. This is where our appendix would be located. Do you have any tenderness here?
No.
Perfect. So we're gonna also be performing the psoas and the psoas sign and the obturator sign to check for appendicitis. So we'll start with obturator sign. I'm just gonna lift your leg up like this, and we're going to just turn it this way. Any pain, tenderness? Just keep rolling, just keep rolling.
I thought when Obus was teaching you.
So next we're gonna be doing the obturator sign. We're just gonna lift his leg up like this, and we're going to be tilting inward. Any pain or tenderness? All right, perfect. That was a negative obturator sign. We're also gonna be doing psoas sign. Can you just lift your leg up for me? Any pain?
No.
All right, perfect. And that would be negative for any appendicitis. It's fine. We're also going to be checking with Ravsing signs. It's another sign that's just going to quickly. We're going to deeply palpate down here on his lower left. Quickly take out. And if he has any tenderness on the right side?
No.
No. So that was a negative Ravsing sign. And this was completely negative physical exam for appendicitis. So normally in an older patient or somebody who had any abnormalities in their physical exam currently with the abdominal exam, we would refer them for a rectal exam. However, because this was negative and due to our circumstances, we won't be performing that today. As we continue through our physical exam, we're going to go through our pulmonary exam, always starting off with inspection. We're going to check out the anterior wall. We're just checking for any trauma, lesions, any respiratory motions and signs that would lead to our clinical documents to infer any distress. Is there any, can you just breathe in and out really quickly? Alrighty, there's no sign of accessory muscles being used, the sternocleidomastoid or any intercostal muscles. So, and we're also checking the back. Can you just take a deep breath in for me? Perfect. Everything looks symmetrical as well in the back. All right. Cool. So our next part of our exam is going to be the palpation stage. We're going to be combining two, testing for any tenderness. So do you have any tenderness here?
Nope.
You're going to say 99 for me?
99.
Perfect. Any tenderness down here?
Nope.
Say 99 for me?
99.
Perfect. Any tenderness over here?
Nope.
Perfect. And
99.
perfect. That was negative for any tenderness. And when we're checking for having him say 99, we're checking for fremitus. And that would be a sign for any consolidation that we're testing for. So we're gonna do the same thing on the other side. Any tenderness up here?
Nope.
Perfect. Say 99 for me.
99.
Tenderness?
Nope. 99.
Okay. Oh, yeah, I know.
99. No. 99.
Perfect. This was negative for any tactical fremitus that would lead to our suspicion of any consolidation, and there was no tenderness on palpation as well. So next we're going to also take and listen to all 7 sides, areas of his anterior surface. We're going to warm up our stethoscope a little bit just for patient comfort. Just take some deep breath. Breathe normally for me.
And it is 10 centimeters. It's 7 is smaller.
7 like 7. Do you want to move the table?
There was no evidence of any crackles, rails, or wheezing, and there was no apparent stridor as well on auscultation. Using the same step ladder technique, we're going to ask our patient to hug themselves to move the scapula out of the way, just like we did for palpation. Alrighty. Go ahead and breathe normally for me.
Palpating the squeeze in the left. No spleen is palpated. Now we're going to be percussing. No splenomegaly present.
For that, so you auscultated, you palpated.
Yeah.
Maybe we'll just do cardio and everything else.
Yeah.
It's up here.
Perfect. Same thing on the other side. On the posterior wall, we didn't hear any crackles, rails, or wheezing, and there was no evidence of stridor as well. So we're also going to be doing a special test. We're going to test for egophony. Same procedure as regular auscultation, just going to go in the step-ladder approach. Tim, as I go down, can you just say E for me?
E, 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 E.
Perfect. Egophony was negative for any consolidation. If there was any consolidation present, it would go from E sounding to A sounding. So now we're going to move on to the percussion aspect of our physical exam. So we're going to start at the apices right over here.
Wow. I felt like I was gonna go.
Second intercostal space. So I'm just going to move over a little bit.
Right next to the microphone.
All right. So we were just checking to make sure that everything was resonant and symmetrical, which everything was. So this would be negative for any abnormalities of the sort. The next part of our physical exam, we're going to be doing the posterior aspect, and we're going to be percussing on the backside. Right? So Michael, can you just hug yourself really quickly? Perfect. Just moves the scapulas out of the way to give us a little bit more room to percuss. So we're just gonna go ahead and look for it right here. Sorry, I'm just gonna get on this side. And everything was negative for any consolidation. Everything sounded symmetrical. And so now we're going to move on to the cardio exam. We're going to be first inspecting as always. We're just going to check across the thorax, just going to make sure that there's any indications for any abnormal pulsations, any heaves, any difference in scarring, which doesn't seem like we do for our patient here. Next, we're also going to be doing the measuring of a JVP. This is just going to make sure it's more of a screening process for any right-sided heart failure. So we're just gonna grab our tools here. And we're gonna look for the sternal angle. And we can put our ruler there. Now, if you want to just zoom in a little bit, we're gonna look for his jugular vein in his neck. I'm sorry. Can you just look a little bit more to the left? Thank you. Alrighty. So the highest point that we see is right around here. So what we do is we take the straight edge and we are going to measure the JVP that way. All right, so we're getting about a 2.5 centimeters for his JVP. We're gonna say that that's negative for for that right-sided heart failure that we were screening for. And we can continue with our exam. We're also going to be checking for his carotid pulse, just to make sure that we can differentiate the jugular vein versus the carotid pulse. We know that if we're able to pulse, if we feel a pulse, that is our carotid artery. Okay, and then over here, we'll do the same thing. we saw our JVP. And we can't feel any pulsations, so we confirmed that that was our jugular vein that we were measuring. The next portion of our cardio exam, we're going to be conducting the palpation portion. We're going to start off with his carotid arteries. However, because we want to check for any potential bruits, we're going to auscultate first, then we'll palpate the carotid arteries. So let's start off there. And for bruits, where you want to use our bell. Okay, it looks like we have the upstroke, amplitude, symmetry. It was very symmetrical, and we were negative for any thrills as well. So now we can go ahead and palpate. One at a time, because we don't want our patient to syncopize. Perfect. I didn't sense any abnormalities as well, so we can continue with our exam. So now, Michael, I'm just going to ask you if you can get into the left lateral decubitus position. I just want you to lean over. Thank you. So right now we're going to be checking his point of maximal impulse, which is going to be by our fifth, where the mitral area is. So we're going to go right here using the tips of our fingers, making sure that we can feel the point of maximal impulse. And there's no abnormalities there. Perfect. You can lay back down. Alrighty. So now we're also going to palpate the valvular areas for any thrills with the balls of our hand. So what we're going to do is we're going to go second intercostal space. We're going to go right here. This is going to be our aortic area. We feel it very faintly. We're going to move over. This is our pulmonic area. Go a little further down for our mitral area. No, I'm sorry, your tricuspid area. And just one more time, checking that point of maximum impulse. We want to go here. And everything looks like it's within normal limits. So now we move on to the auscultation portion of our cardiophysical exam. We're going to be examining on the right side of his chest the aortic area, which is in the second intercostal space, pulmonic area in the second intercostal space on his left chest. Then in our third, fourth, and fifth, we're checking for our tricuspid area, checking for those valves right there. And then a little bit more laterally, we're checking for our apex, which is our mitral valve as well. So we're just going to go ahead and check. We're going to be checking on both sides. We're going to start off with our diaphragm for those higher pitched sounds, and then our bell for our lower pitched sounds. And for this portion, we want to follow the midclavicular line, which would be right around this area.
Stop.
Okay, cool. So now we're going to be using the bell to check for any low-pitched sounds, for any bruits or any abnormalities of the sort. Same areas. Here we have our pulmonic. Here we have our aortic, Here we have our pulmonic. We're back to the tricuspid on the third intercostal space. Fourth intercostal. And fifth intercostal once again. And we're going to follow that midclavicular line and check once more. Perfect. So we didn't hear any murmurs, any gallops, or rubs in our exam using the bell or the diaphragm, so we continue with our physical exam. So just to clarify a little bit more about what we were conducting during auscultation or listening for during S1 and S2, we're using the diaphragm of our stethoscope, and during using the bell, we're listening for any abnormalities like S3 and S4.